So let's get started on the second part of the lecture. It's kind of a long lecture, but burns are quite thorough. There's a lot of them out there. We talk about electric shock and burns. There's different ways through actually utilizing a defibrillator, as we see with the CPR. They can cause severe damage. They can stop you from breathing. They can actually stop the heart. Lightning is another source. Just truly an electrical shock through, an outlet or anything like that can cause a burn. It will run through the body and then eventually ground itself, and you'll have that burn. What happens is there's a result from coagulation necrosis. It's caused by intense heat generated from the electric current. So it almost kind of cooks it if you think about it. May result from direct damage to nerves and vessels, causing tissue anoxia and death. So it is going to cause some issues and death with tissue where it goes through and burns internally. And there's not really much we can do with that. We just have to monitor the patient, and anything life-threatening, definitely initiate different interventions to help support their life, intubation, drips, whatever, fluid resuscitation. If you see the picture here, you can see this gentleman. He's standing on a rubber mat. Ground yourself. If there's lightning, ground yourself with rubber. You say you're grounded in the car, different things. Stay out of anywhere there's a water current, because electricity will travel through water very easily. You don't want to be standing in a puddle and touch a live wire. I mean, it's just different things like that. You always think safety. Scene safe. That is so important. And you don't want to put your life at risk, because then we have another patient or another victim to whatever's going on. So it's very important that you stay safe always. Electrical burns, sparks can actually ignite on clothes, causing to have two different kinds of burns. You can have an electrical burn where the current runs through the body, and then you can have a thermal burn where something's smoldering or burning that can create a burn on the outside. If the current passes through a vital organ, this can cause life-threatening issues. This will create a life-threatening situation that has to be addressed by an emergent care setting. You need to call 911. You need them to be moving very quickly to get to you. If anybody's ever burned, no matter what, minor, major, whatever you think, if you're in the field or out in the real world, get help, because you don't know the damage that's done, and you don't want to be sitting there and something really bad happened to the person just because you didn't have somebody check them out. Always go to a hospital, have someone take a look, assess. I know it's a little different with the COVID right now. People are not wanting to go, but you still need to get the care. So at least call 911 and let EMS respond and do an assessment and take a look. Different things depend on the severity of the injury of an electrical burn. Amount of voltage, tissue resistance, is it going through something liquid? Is it going through something solid? The current pathways, where is it going? Surface area and duration of flow. This is an electrical burn, just kind of showing you the difference. And you can see it produced heat coagulation of the blood supply and the contact area as electrical current passes through the skin. So you can see that happening. Another electrical burn we're seeing again, you see an arrow being pointed. It's a bad burn. Chemical burns. We deal with a lot with chemical burns, different things. I mean, we deal with chemicals every day in our cleaning products, and with dealing with batteries, dealing with just different things we come across at home, and also in our workplaces. And so it can happen. I mean, even out gardening, using different things, different fertilizers, different chemicals and stuff on plants, you can create a chemical cloud. You can burn yourself badly. So you need to read directions carefully, explain that to your patients. Understand that it is tissue injury and destruction due to acid, alkalis, and organic compounds. Alkali burns are hard to manage because they cause protein hydrolysis and liquefaction. So damage continues even after the alkali is neutralized. And I think I shared on the previous, the gentleman that was pouring the cement for his driveway and it filled his boots. He kept on working. By the time he came to the ER and we pulled those boots off, the flesh just came with them. That was an alkali burn. They're bad. They're bad. You don't see as many as you would think acid, because we think acid is, how dangerous it is, but the alkali, I didn't ever even thought of it. Interesting. Chemical burns, it can injure the skin, the eyes, your respiratory system, liver, and kidneys. We have to be very careful. The eyes are very, very sensitive. You can do different things, but you definitely, if there's a chemical that goes into the eye, flush the eye. We have eye centers in certain areas and workplaces. It is important to know your environment, important to know what you're doing. If you are dealing with patients with this, it's important to understand that they need their eyes flushed as long as the chemical allows. Skin, you want to get the chemical off the skin also. If not, it can continue to burn and cause damage. If it's creating an inhalant and you inhale it and you're having an internal burn, you're burned by the chemical that way. That can be very detrimental. You need to get the patient away from that. You need to ask the patient, where did you inhale this? How long were you inhaling this? What happened? An example of this is actually, it's a very sad situation, but my father was a school teacher and a student, his classroom was next to the gym, and a student went in, was cleaning the mats with a bleach that was a very strong bleach, stronger than your average household bleach, that had been purchased by the school. And the child, the high school kid, he didn't know any better, and he mixed it with another, he was mixing the spray and cleaning. Well, it created a chemical cloud. It was an ammonia bleach mixture, which can be very detrimental. And one of my dad's special ed students started to cough. She had asthma, and he noticed it, and he kind of smelled something. So he got all the students up and he took them out into the fresh air, which was the right thing to do. But where it became an issue is my dad went back into the classroom. He opened up the windows to air out his class, and in doing so, inhaled for that time frame all of this chemical. And it actually he did have an inhalant burn. And he went home. He went up and told the office what had happened. He went home. And that was either a Thursday or Friday. And Saturday morning when he woke up at home, he was white as the sheet or the paper. And he had had a little anoxia during the night, woke up confused, very pale. And my family that was there, my mother and my sister and my brother-in-law, he came around. He just came around and pinked up, and they thought, well, he's okay. Everything's okay. And from that, this whole clotting cascade issue came, and he had multiple TIAs, and then eventually had a major stroke. And in a pretty long period of time, it took him, because he was a healthy man, passed away due to the complications. So that's where you can have a chemical burn that you might not die today from. It might happen today and you don't die today, but the damage done can create, and that's how we need to think. Chemicals are flushed with large amounts of water, with some exceptions. There are some things you don't add water to. Vomiting is another thing. Have them vomit if they drink it. It's not always, though. You need to know for fact. So who do we call? Poison control. If something's ingested, to say this is what's going on, what should we do? immediate transport to the hospital and inform the care provider. You want to know what it is. And if you don't know, if you come on scene, this person's whatever, or you're at home and this happens, you want to make sure that you grab whatever. If you have to put it in a bag to contain it, you don't want it on you, you don't want it, but you need to. Even nowadays, the biggest thing I love to do is take a picture with my phone. I think everybody does actually, but I'll take a picture of something and then I'll look it up because I'll forget, or I'm doing something, I want to take a picture so I can remember. And also how long you irrigated it and with what, did you use the tap water? Did you have, whatever, and any other injuries that might have gone along with that? Because sometimes what happens is a person falls, hits their head, and you have other injuries going on, or they fell and broke their arm. And not only do they have a chemical issue, but they have a broken arm. So there's other things that have to kind of be addressed. The pre-hospital phase for inhalant injuries, we want to observe for signs of respiratory distress and compromise and treat them very quickly. No airway, no breathing, no life. It is as simple as that. You need an airway. So if we have an inhalation injury, we've inhaled something that could create the actual airway to swell and become compromised, or that you have a issue where there's a burn and tissue sloughing off, or whatever's going on, you want to make sure you get immediate help. You want to treat very quickly. It's not something you wait on. It's not something that said, let's watch it. It'll be pretty bad. So that's your pre-hospital phase. Emergent phase is the period of time required to resolve immediate problems resulting in the injury. So in the pre-hospital phase, we are making sure they have an airway. We're getting some help coming to us. In the emergent phase, it's the period of time required to resolve immediate problems resulting from the injury. So we need to, if you have a gaping, bleeding wound, we need to put pressure on that. We need to cover that up. If you have a limb that's broken and flapping around out there, then you'll want to, go ahead and splint that and secure it so that there's no more damage being done, making sure you have a pulse and those things. It's so important. But that is the emergent phase. We are dealing with immediate problems, not the whole gamut, but the immediate problems. Usually last up to 72 hours. Primary concerns are onset of hypovolemic shock and edema. So we worry about if they're going to go into hypovolemic shock. Phase begins when the fluid loss and edema formation and continues until fluid mobilization and diuresis begins. So I want to go back to this emergent phase, because if you go to the emergent phase in your book, let me get to it. It is on page 989 in your DeWitt Med Surg textbook, and it can last up to 72 hours, but it averages 24 to 48, but may last as long as 3 days. It just depends on what's going on. But the first hour of treatment after burning can be crucial to the eventual outcome of serious burn. Other life-threatening injuries must be treated first. So we need to know details of what's happened. What's the accident? What's going on? Why are they burned? What happened? Is there any other injuries? So it's just important. It's become a Nancy Drew. We need to investigate and figure out what's happening so we can solve the mystery. Knowing the cause of the burn is so important, because that's how you can treat them. If they have a chemical all over their body or something like that, or they ingested something and you're not sure what it is, you need to be really careful. One thing is you want to get rid of things off of the body if it's causing damage, but you have to be careful, because some things you can use water, some things you can't. Some things they say to just take a towel and wipe off and not dilute, just different things. So it's so important. Just remember, if they have their faces burned, if you have anything black tinge to the nares, if you have any black tinge in the mouth, if they're coughing up any black sputum, anything like that, you see singed eyebrows, singed bangs, singed whatever on the face, be concerned for an inhalation burn, and know that we need to intubate that patient pretty quickly because they could lose airway. Once the shift of fluid starts, that's when the edema happens and we can occlude airway. This is when it starts in that emergent phase. This is a perfect example. I love this picture in the sense of, it's gruesome, don't get me wrong, but I love it because it really, really shows you what happens when the fluid shifts. This picture, the one on side A, is the patient that was burned. He has a tube down. He ends up with facial swelling. And I want you to look, this is facial edema after 24 hours of the initial burn. And you see, if we had not, and it's not my patient, but if they had not gotten this patient intubated and sedated, there would be no way to get a tube down due to edema. That's how quickly, once that fluid starts to shift, the edema starts to happen. So I think that just speaks volumes. It should just drive it home for you that it's quick. We have a fluid shift and edema happens. If it's a facial, neck, or chest burn or injury, we need to be concerned about airway, 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 airway. This is just the emergent phase, the complications that can happen. I'm not going to read a slide for you. You can kind of look at what happens. It's in your book. It's also here in the slide. It's a good thing. Different things can happen. We do have a urinary system, kidneys. You know, I'm all about the kidneys. Decreased blood flow to the kidneys causes renal ischemia, and we can have acute tubular necrosis. We can have ATN. So we can really get compromised here, not only with the heart, with the lungs, but then the kidneys. So it's important that we're on it. The acute respiratory failure, these are ABG values. If it's less than 60, the PaO2, SAT less than 90, PaCO2 greater than 50, and the pH less than 7.30. They're having actually oxygenation failure. They're just not oxygenating. They can't breathe. They're having ventilatory and oxygenation failure. They become hypoxemic. And so if we're not oxygenating, what's happening to our tissue? It's dying, right? Correct. And that is not good. We're going to start to do different things, the body, and it's going to take us a little bit to, it'll take us a lot. If we get to these points, we're in trouble. Hydrotherapy is a way we can actually debride. It's important about debriding and wound care. This is actually the table you can see. We have everything covered. You notice we're staying sterile. There's a patient. It's a sterile field all over, and they're working on the patient. Acute phase begins when the mobilization of extracellular fluid and subsequent diuresis starts to take place. So the acute phase is concluded when the burn area is completely covered by skin grafts or the wound is healed. So that's important to know. So we go into this, once the fluid, you've got all this fluid shift, but once it starts to move and go back in cellularly and we begin to start to absorb the fluid back in, that edema is going away, we'll start to diurese. The kidneys will start to, let's get it off, and you'll start to diurese. That is the acute phase. It ends when the wound, the burn, is healed. Or, and this is the ticket, you have a skin graft covering it because it's healed, right? We've covered it up. If not, it's open there, it's still seeping, all these things are happening. But if we let it heal on its own, it's going to take days and days and days, and then it will heal. But if we get a skin graft, then it's considered the acute phase over. That's kind of interesting. This is a split thickness sheet skin graft to the hand. You can see where they've sewn it. Eventually what will happen is this will connect and everything will heal. And you will still have some scarring noted and discoloration because of the graft, but it will actually look much better. But I like to show that because it is kind of interesting, and it covered quite a bit. If you look at that, they did a good job. I'm sure that doctor appreciates. Radiation burns. They can really create and cause some really bad burns. I've actually seen a couple that have been pretty bad from women with mastectomies that have had some radiation therapy done also. And it burned, there's one lady burned all the way across her back. It was, it just looked horrible and painful. And it takes a lot to heal these with the radiation burn. My grandfather had radiation, and I think I've never really gotten a clear story on it, but I just know that he did have radiation, and my mother had said that it burned him, and it burned in with rectal involvement, unfortunately, and so he really suffered. It never healed, and he really suffered with it for years, and then passed away from actually a myocardial infarction. I sound like my whole family's falling apart, but they're not, I promise. This is gut wrenching. Putting babies in hot water and not checking temperature. Little baby put down in scalding water, or see the blister, do not pop it. The blister, we've got the skin sloughing. It just breaks my heart. Breaks my heart. I can't stand it. This is another, it's talking about the fluid shift, because that is so important. I mean, that fluid shift in the edema is huge. So on Monday, she has a burn. We see it here on her hand. She has a ring on. That's on the 6th. If someone gets burned on their hands or neck or anywhere there's jewelry, wrist, whatever, the jewelry needs to come off. Even if it's not affected by the burn, it needs to come off due to the shift of the fluid and that swelling and edema that's going to take place. Because if not, then you're going to be cutting jewelry off, and you can actually cause more problems for the patient. So as you can see, there's her hand, and we look at the next day, okay? And it's a little harder to see there, but you definitely can see in the morning, it's just slightly a little more swollen, not really much from the day before, but by the later in the day, that afternoon, I want you to look at the swelling. That's when it started. So you have the burn, everything's going on, and then that time frame, pow, and we start to have that fluid shift, and there we are, we're swelling up. Now, if she had that ring still on, we would be having to cut that off because it would compromise circulation and things there. This is a picture that is a 2nd degree hand burn. It shows mixed different grades of 2nd degree burns. So I don't know if you recall, but the picture that I showed that I love with the epidermis, the dermis, and how the stages and full thickness, partial thickness, full thickness, and then different degrees, 1st degree, 2nd degree, 3rd degree, 4th degree burns. This is just saying that this is showing you a hand that's burned and the different degrees that you can see throughout the hand. So you don't always get that perfect little, it's a 2nd degree burn, or it's a 3rd degree burn, or it's a 4th degree burn. It's normally the deeper, the more emergent, larger the burn to the patient, the thicker, the more stages you might have. So if you have a stage 4, you'll probably have some stage 3, stage 2, 2nd degree, 3rd degree, 4th degree. If you have, bad sunburn, you might get a little slight 2nd degree, but you are severe 1st degree, it's not going to feel good. There are some slides in here. I did not include them in the lecture piece due to posting on YouTube, but I put a little Will Ferrell in there. I just love him. He's funny with his little sunburn, but please use your sunscreen, because believe it or not, there's a whole section in your book on not getting burned from the sun and using your sunscreen to prevent skin cancer, because we know that can be an issue. Okay, here's another little baby. With an arm burn, I want you to look, pulled down a cord, came down, the hot scalding liquid came down, burned baby. Nobody wants to see children. It's so important. Safety, 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 right? Okay. And this is DeWitt and Stromberg's Med-Surg book. So that kind of wraps up burns. I'm going to stop my share. And I'm just going to talk a little bit more. I want to kind of look. So some of the things with burns that we want to remember is that infection is one of the things that we need to really worry about. So we want to use sterile dressings. We want to cover the patient with sterile sheets or whatever. A lot of areas now have sterile packets for burns. You just open them up and there it is. We know that if we get to a full thickness burn, that we have burned off that layer, that we lose fluid. And by losing fluid, that means we can go into hypovolemic shock. So it is so vitally important. And what do? We do our rule of nines. I don't want you to memorize that, but I want you to understand that the rule of nines is the body is broken down by nines, 4.5, 4.5, that's 9 for the head, front and back. It could be side to side, but the whole head is 9. 18, 9 and 9 is 18. So the torso is this long from the neck down to the waist area. Rule of 9. So we're going to assess that burn. We're going to give it a percentage, and then we're going to go to Parkland's formula, and we're going to take 4 times the percent of the burn from the rule of nines times the weight in kigs or kilograms. So you take your pounds, divide by 2.2, that gives you that number, equals that amount. Whatever that big number is the number of milliliters of lactated ringers that you're to give in 24 hours. I take that number, divide it in half, cut it in half, and the first half I'm going to give in the first 8 hours from the initial time of the injury. So not the time they get to me in the ER, but the time that they actually were burned in their home or burned wherever. Then I'm going to take the second half of the fluid and give over a 16-hour period. It's going to be a little less. Then if you think about that, I'm giving that big amount in 24 hours because 16 and 8 is 24. So I hope that makes it kind of easier for you to understand. Remember, if we have anything with the face, in neck or chest, we think that airway, airway, airway. I'm just kind of looking at some stuff to make sure we're on track with the burns. The other thing with burns that if you have a patient that is burned, let me see if I can find this in the book. We also want to make sure that we treat the patient for pain. And for minor burns, that would be acetaminophen and ibuprofen. But for really extensive, deep tissue burns, full thickness burns, even second degrees, if we get to a certain point, it is very painful. Burns are painful. When you get to a 4th degree, you're not going to feel anything because you've burned through the nerve and things. So that's another thought. So when you go to see them cut to do a escharotomy, that's an incision into the burn with a scalpel or electrocautery, and it relieves that pressure from a circumferential burn. So if you have a burn completely around an arm, completely around my arm, when that damage happens and the edema takes place, it'll start to compress, almost like a boa constrictor. It's going to start to compress, and by doing that can create compartment syndrome. It just does different things. It's going to shut down the circulation to the arm, and so they need to cut. And because it's if it's a really bad extensive burn, that cutting, they don't actually feel, but still medicate your patient, because I'm going to say this, if it were me, I want to be medicated if you're going to take a scalpel to my body. Makes sense, doesn't it? The other thing I want to talk about is what we do when someone comes in with a burn. Now, out in the field, if the patient's at home or out in the field, we don't remove any material or anything that's stuck to the burn. That is in the hospital phase of care for the patient. So we do different things. We're definitely going to want, I'm trying to find it in your book because I know it's here. I read it. Okay, here it is. So we definitely want, patients should be undressed and covered with a sterile or freshly laundered sheet. However, if the clothing is stuck to the burn area, it is not to be removed before the patient is in the hospital. Take off all the jewelry, rings, bracelets, watches, necklaces, anything like that, earrings if they're up there. Just get everything off of them jewelry-wise. Because they'll get a tourniquet effect from that. As the fluid shifts and that edema takes place, it creates havoc. We want to don't put anything greasy, anything with a grease base to it, salves, ointments, any kind of greasy material to the burned area. It just creates more issue. You're cooking the skin even further. It can be very painful, increases a possibility of infection. You know, we talk about Neosporin, you know, used to, we slap that stuff on everything if we could. But you know, it actually covers and creates a barrier so that bacteria can just get in there and do its little thing. It can create more havoc than good. So be very careful when you use things like that. And I don't think everybody always realizes that. Do not disturb the blisters. Do not pop a blister. Don't make me. You know how I am. Don't pop a blister. That's how I feel. You don't want to, because we're just breaking, that is trying to heal itself. And by opening that, it's just opening the patient up to one, it delays that healing, dries that up. We want to keep that internal piece moist, whatever the liquid is, trying to do its thing. It'll pop on its own eventually, most likely. But when it's ready to pop, it'll pop. And the other thing is we're opening up the tissue and skin to be susceptible to infection. So don't do that. You keep them NPO. We don't want to give them, it's not the time to eat and drink at this point. And the reason being is when everything is going on and we have all these things happening within the body, things are being shunted, and it's being shunted away. We're trying to get things to the brain, to the heart, to the kidneys to keep ourselves alive. So the whole bowel GI tract goes wanting. And because of that, we can have they are susceptible to paralytic ileuses. So don't give them anything by mouth. One, with that much pain and discomfort, it can make them very sick, nauseated, all of that. Two, you most likely might, well, not most likely, but possibly could be intubating the patient, and you don't want to give them anything by mouth. And the other is that due to the emergent situation, there might be a paralytic ileus coming up that you're not aware of. And what has to happen with that is you put an NG down to low intermittent suction and allow that to resolve. And so it can take a few days. The other thing to think about with burns too, I want to make a note of, is the nutrition. In your book, I did want to point out that on page 997, the nutritional support, they do need for healing a high protein and calorie diet, because with a large burn, we need all the calories to help with the healing process. The body will get behind. So you need that high calorie, high protein. We need to be healing tissue. So that's why it's so important. They need to drink a high protein, high calorie drink if tolerated. We want to restrict free water. It's very important. Dietary supplements, they'll need A, C, and D, zinc and copper also, because they're missing that due to what's happening. They'll have a high glucose load, and so the high carb intake can lead, a high carb intake can lead to hyperglycemia, dehydration, and respiratory problems. So we're looking for high protein and calories, not high carb. So even though you want to eat all the Krispy Kreme donuts in the world, that is not the food of choice. So I just want you to be aware of that. Remember, there's body image issues with these patients. But the main thing I want you to know is that if we have a patient that has a horrible burn, and it's a new burn, they're just coming in, what do we want to do? Well, we want to keep anything on them sterile, correct? We want to take off their clothing, nothing stuck to them until they're in the hospital setting. They're in the field, you leave it stuck to the burn. Don't be ripping off stuff. When they get in the hospital, they'll remove it carefully and work with what's going on. Remove all that injury. Don't put any ointments on the burns. No butter, no grease. Got to stay away from all those southern, you know, which grandma, great grandma tried to tell you to do for burns. Run minor burns under cool water, remove anything that's burning the patient, and seek help. Have them seek help, tell them to seek help. And if you're in the ER working, then you are the help, and be ready to intervene. Assessment, 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 head to toe, looking them over, understand what's going on, and move quickly, because if you don't, you might miss something, and when that fluid starts to shift and the swelling starts to happen, things can go down very quickly. So that's all I have for you on burns. There's a lot of information. Make sure that you look through from page 986 and go ahead and read on through to 998. Okay, and that just covers different things, but it's very good to know what and how to do. So I hope you enjoyed burns, and we will talk about shock very soon, just not tonight. I hope you have a good evening. Bye.